have Dr. Abitbol, who is the Associate Director of Radiation Oncology in Baptist Hospital. Dr. Abitbol, welcome to our interview.
Thank you.
He is a prolific writer and is a very experienced doctor, and it's our great pleasure that he can answer a couple of our questions regarding the treatment of different types of benign and malignant lesions and different diseases with the radiation approach. Dr. Abitbol, what type of patients do you usually see in your practice?
Well, I see mostly, almost exclusively, cancer patients who have solid tumors, and they can vary anything from cancer of the brain, so-called gliomas, to gynecological cancers, head and neck cancers, lung cancers, pancreatic cancers. So essentially, we see just about every solid cancers. We do have some subspecialization within our group, and I see a great deal of head and neck cancers.
Yes. Also, in your research, that you have plenty of publications. In your research, you particularly emphasized your attention on treating head and neck cancers. And when I was preparing for the interview, I found really interesting papers that you published with Dr. Troner on stage 3 and 4 head and neck cancers.
Yes, we started in earnest a program in 1988. Initially, I was collaborating with Dr. Kazi Sridhar at the University of Miami, and we subsequently have continued this program since 1988, primarily using intramural research trials approved by the Institutional Review Board to address questions on how to integrate radiation therapy with chemotherapy. And that has led to a number of trials starting in 1988 to the current time. And we've moved quite a bit in terms of progress, in terms of the techniques of radiation. And also the chemotherapy has evolved quite a bit during that period of time. And we have achieved what we think is very, very good results in terms of control of these cancers and cure. Perhaps the more challenging issue with these cancers is how to deal with the associated side effects of the treatment and the long-term effects of treatment. And we're working very diligently to tailor the individual treatments to the needs of the patient and to their particular cancers. And our colleagues in head and neck surgery have been extremely collaborative and collegial in terms of determining and joining us in this effort. And they themselves have been spearheading a very significant innovative program in terms of robotic surgery to do surgery that was totally unachievable until recently in dealing with cancers at the base of the tongue and the tonsil. These are cancers now that are increasingly more commonly seen in the United States because of the recent human papillomavirus biology that has been associated with these cancers. These are cancers that are basically caused and induced by this virus, just as the same virus is inducing cancers in women with cervical cancer. So we are collaborating with these physicians and also with my medical oncology colleagues, Dr. Lisa Reali and Dr. Michael Troner. And we have a weekly tumor board where patients are presented and discussed, the imaging studies reviewed, pathology reviewed with pathologists and a radiologist, and the patients examined. This is quite a novel conference to have in a community setting. Although it's very common in the university setting, we have used this approach here for the past 20 years and found that this is a great vehicle to guide us in terms of joining different modalities together and achieving the best cure.
Okay, thank you. Also, what you published was the really great long-term survival and even 3-year survival with these new modalities in the patients that participated in your research in comparison to overall data in the country, which is about 50%, 50 to 65% 3-year survival, and you were able to achieve quite a bit, more than 75% of 3-year overall survival, which is very impressive.
Well, the head and neck cancer has changed quite a bit from the time I started practicing over 25 years ago, and the curability when I started off was down in the teens, and now has gradually improved to the 40, 50%, and now increasingly for some of these oropharyngeal cancers, which make up more than 50% of the head and neck cancers, the curability is approaching 85%. And this has been the result of really better, more effective treatment. I'm not sure that it's really earlier presentation and earlier stage of these cancers. They all tend to be fairly advanced in stage at the time of presentation. But our results are very much on par with most of the results that you would see in academic centers. And we still are working very hard to reduce long-term side effects, particularly of chronic swallowing dysfunction in these patients.
Yes, thank you. Also, what we wanted to ask you, there are plenty of strong anti-tobacco programs in the country. And for example, Stop Smoking Florida, the advertisement is on the TV very often, and the smoking is prohibited. So basically, the smoking did decline during last couple of years, but the statistics with head and neck cancers is still rising. So what do you think is the major problem? Is it the HPV virus, or that is associated with the younger population, or what do you think could be the major factor here?
Well, historically, the major factors for causing head and neck cancer has been smoking and alcohol abuse, and the two act synergistically in causing these cancers. And while the overall incidence of head and neck cancer has minimally increased, it has probably stabilized. It has an overall incidence has reduced as far as those cancers related to smoking and alcoholism, and these are becoming less and less frequently seen. What has surpassed these types of cancers has been the HPV-induced cancers, which are seen, as you mentioned before, in younger patients, and more typically patients who are non-smokers or who have little smoking history. So these are different types of patients, and luckily these are patients who are healthier, that do not have all of the associated health issues related to smoking, like lung cancer, like emphysema and heart disease and vascular disease, and they're much more curable. They're functioning members of society, they're working, and so achieving a cure is readily achievable nowadays, but making them functional and making them totally able to swallow and to speak and to go back to work is a very challenging situation.
Dr. Abitbol, can you please say a couple of words about new approaches, for example, with brachytherapy in head and neck cancer treatment, and the CyberKnife? That is really a new technique,
Sure.
which allows to significantly cut the postoperative rehabilitation time for the patients.
Well, brachytherapy means in Latin short arm, and it's been used in the very accessible tumors historically, using radiation therapy initially with cesium and then more after loading catheters. Its role actually in the head and neck region has actually greatly diminished as better techniques of external radiation therapy have evolved. And probably the most commonly used technique we use is intensity modulated radiation therapy, which allows us to concentrate the dose where the tumor is and shape the dose in a very conformal fashion to avoid the critical structures that are in the head and neck region. These include the salivary glands, the spinal cord, the jaw, and the more other critical structures include the eyes, the brain, and so we are much better able to deliver very, very sophisticated, complex radiation therapy that uses very good machines that are engineered to deliver that type of treatment. We also work very closely with our medical physics colleagues who are our partners in delivering this type of care, because this requires a lot of medical physics support.
Also, on the last head and neck cancer conference in April in Baptist Hospital, there was an announcement about new variant, system variant that will be delivered to Baptist Hospital, and you will be able to provide different type of radiation treatment to your patients.
Yes, we have a true beam that's currently being installed at Baptist Hospital and should be hopefully operational within the next few months. And this is one of the improving techniques of external beam radiation therapy, which allows us to do more precise type of radiation with much smaller collimation, meaning the radiation can be shaped much better. It can be arc therapy, which also allows us to do much more precise type of radiation therapy. And so these are advances that we see as a result of great interest on the part of linear accelerator companies and to develop better tools in terms of radiation therapy. You mentioned also the CyberKnife, which is one of many also tools that's available, but the role for CyberKnife, or what's called stereotactic ablative radiotherapy, has a limited role in head and neck cancer. It's primarily used in the United States for treating cancers of the brain, mostly cerebral metastasis, benign tumors of the brain like schwannomas and meningiomas. And it's also used increasingly so for treating lung cancer in patients who are medically infirm and cannot handle surgery. And we're starting to treat quite a few of these patients with this type of stereotactic ablative therapy. Typically, the treatment's given in 3 treatments. In the chest for these lung cancer patients, or in one treatment for the brain tumors. And it's an outpatient treatment. It's quite a novel, highly effective way of concentrating the radiation, very high doses, but highly conformal doses to spare the surrounding tissues injury from radiation. The results are very good in the brain, and they're also excellent in those medically infirm patients who cannot have surgery for lung cancer.
Is it similar to Gamma Knife?
Gamma Knife is another technique. Historically, Gamma Knife was the first radiosurgery machine. It was used exclusively for cranial tumors, that is, for brain tumors. It continues to be used significantly, and we do have a Gamma Knife within our system here at Baptist Health System that we're using. We also have the CyberKnife, which is a machine that can be used not only for cranial tumors, but also for extracranial tumors in the lung and elsewhere in the abdomen and the spine. And that one is also very commonly used.
Thank you. Dr. Abitbol, thank you for your time and for the interview. And if you can just say a couple of words to our patients and the colleagues who are watching us.
Well, I would like to thank for the opportunity to be interviewed, and I'd like to also thank my colleagues with whom I collaborate in radiation oncology, Dr. Alan Lewin and Dr. Ali Garcia-Serra, who have been very supportive of our program in terms of directing and setting the tone for this program. And also I'd like to thank my colleagues in medical oncology and other specialty and in thoracic surgery, in head and neck surgery, GYN oncology surgery, as well as in abdominal surgery, particularly the colorectal surgeons and the surgical oncologists who work so closely with us. We're very lucky that we have a very supportive environment here from the administration who allows to interact very closely with them and also provide us with new resources all the time, including the new TrueBeam machine here at Baptist Hospital. The setting here is very pleasant. We have weekly conferences in just about all subspecialties, including lung cancer, GYN oncology cancer, and head and neck cancer, neuro-oncology. And this is a great way to collaborate with doctors, and also it translates and results in better care for these patients who know that we spend the time to discuss their case and review and try to find the best way to treat them.